going on to something really exciting now. It's the great debate. Everything's exciting, but this is particularly good. The topic is personalised medicine is the future. We've got 3 speakers for, 3 people against, 7 minutes each, a bell at 6, and then I hook them off at 7 minutes. And the winner will be determined by the clap-o-meter. Start clapping quietly and gradually increase. Fantastic. Ladies and gentlemen, could I invite all our debaters to come up? I'd like the affirmative team on this side and the negative team on that, the furthest from me. And I'll introduce you when I've got them all in. So this is the affirmative team. Will you meet them one by one? I think so. Let's whip on. I'm going to introduce them one at a time. And guys, remember, if you're using this, could we have the lectern on, please? If you're using this, watching this, guys, it matters, it's technical, like a cannula. Shoot over the top. Don't pop. I hate that. Ladies and gentlemen, the first speaker for the affirmative, arguing that personalised medicine is the future, is Professor Nick Glozier, a consultant psychiatrist at RPA who specialises in sleep and neurological disorders. Please make Nick welcome.
Thank you, everybody. The idea this was a debate was rather bounced on us earlier on this week, and I was a little bit shell-shocked to start with. But then I realised I have the easiest argument to make, and I actually feel sorry for the people coming against us, because the idea that personalised medicine is the future of medicine is so obvious, it's unbelievable. And the reason why it's the future of medicine is because it's the present of medicine and it's been the past of medicine. Medicine is always so much more than the fantastic technological advances we have just heard done by our keynote speaker. It is so much more than the algorithms and the risk prediction and the big data that people say are going to be helping us in the future and increasingly are helping us in the future. We have Watson IBM, we have deep variance, we have amazing machines and algorithms that can pick out risks. But those things are risks. They boil down to raw data. They don't actually bring the human being and the person into medicine. We do not yet have an algorithm for empathy. We do not yet have a gene technology for understanding culture. We do not yet have the ability to find the data science that enables us to fathom intra-individual cultural variations in communication. And so long as every single clinician, every single doctor, every single nurse, every single OT, physio, and all of the other professions allied to medicine are working with people who turn up with histories, with backgrounds, with families, with cultures, with education and jobs and contexts that are so much more than the genes than they are born with. As long as we all deal with that, we will always be dealing with personalised medicine. So I'm not even going to get to the end of my time, I think, because it is so obvious that the future of medicine is personalised medicine. Because to argue against personalised medicine is to argue, as my colleagues are going to argue for depersonalised medicine, impersonalised medicine. And if that is the future of medicine, I do not want to be part of it. Thank you.
Honestly, when I'm mentally unwell next, which could be in a day or two, I'm going straight to that bloke. He's got the gift. A big round of applause for Professor Nick Glozier. Ladies and gentlemen, our first speaker for the negative, arguing against the proposition that personalised medicine is the future. And could I just check, can you hear the speakers at the lectern? Wave if you can hear. You can hear? Okay, good. Enunciate. We're in a slightly echoey space. Sorry, but that's an old ABC trick. Ladies and gentlemen, our first speaker for the negative is Professor Steve Chadman, Head of Renal Medicine. He's known as the kidney guy from RPA, and his passion is surfing. Please welcome Steve.
Go team. Thank you, Julie. May I ask at the back, I have a couple of slides. Thumbs up. Thanks, guys. Now, thanks very much, Nick, for a very brief talk. May I have your extra 3 minutes? Thank you, excellent. I'd like to acknowledge John's wonderful display of factual stuff that really is revolutionary, world-breaking stuff for a tiny proportion of our population, and I'd like to put all of that nice stuff aside and have a little go at John as soon as my slides come up. Here we go, they're up. All right, personalised medicine is the future. I always like to start off by giving my relevant disclosures. This is, I've taken it from an American conference I spoke at a couple of weeks ago. I noticed Professor Rasko didn't exactly have one of these, so I'll make up for that in a moment. My disclosures are that I work for RPA and we see millions of patients. A very small number of them have a definable genetic condition which can be targeted by John and co. Most of them have multi-morbidity stuff that we've got to do our traditional medicine to treat. The second thing I'd like to say is that I work for the University of Sydney. They pay me nothing, but they give me a very nice lab. And the final thing I'd like to say, and Julie, I'll come back to this relevance of this a little later, is that I buy my suits off the rack. John Rasko, I didn't happen to see his disclosure slide. But he has spent a lot of time travelling back and forth to the US of late, I have noted. I'm not sure who he was dealing with, but there are suspicions. Suspicions are not only flowing in one direction, though, and I think John failed to adequately inform the President of the gene homology between hair and possum pheromones. That's a story for another day. So my take on this, and certainly that of our team, is that personalised medicine is the future refers specifically to tinkering with their genes. We don't mean that we can't be people in treating our patients. Nick, we totally agree with you. We need to be real people in engaging people, but we're not talking about that. We're talking about genetic manipulation or not. And this is some of John's fantastic work. I don't need to dwell on this, but just notice the facts. 10 patients, gene therapy worked for 9 out of 10 of those in the first paper John showed, 11 out of 22 with thalassemia. Fantastic. But at what cost in terms of development of the science, development of the technology, delivery of the technology? I'm not sure he's answered that yet. I live in a kidney world. In the kidney world of Australia, we've mapped out the prevalence of kidney disease, and as you can see here, we have close to 2 million Australian adults with chronic kidney disease. We know the drivers, there are multiple: diabetes, hypertension, immunity, and many factors. This is not a simple monogenic issue. What are the outcomes? Death prematurely, sometimes dialysis and transplantation. But the bottom line is that there are lots of people involved, they have multi-morbidity disease, and they need simple, multifaceted, demonstrated effective therapies, such as ACE inhibitors. 50 cents a day for an ACE inhibitor lowers blood pressure, reduces proteinuria, delays progression of kidney disease, and we as taxpayers can afford that. Please ask John the same questions about his therapy. We put some numbers to the cost of chronic kidney disease in Australia and found that the visible dialysis and transplantation costs are about $1 billion a year, but the earlier stages incurred by those other 2 million Australians costs us as taxpayers $4 billion per annum. Now, if we sent them along to John, rattled them through a gene sequencer at $2,000 odd a pop, just to see if we could identify genetic defects contributing to disease, that would effectively double that price, and that's without moving to any form of therapy. So here is one of the great flaws of personalised medicine in the genetic context. What about if we bury into the sharp end of kidney disease where people actually require kidney replacement therapy with dialysis or transplantation? Here we have some diseases that we know about. Diabetes is number one. What about genetic strategies to manage diabetes? Complex, polygenic disease demonstrated over major genetic studies, coupled with environmental factors. This is not targetable with specific genetic therapies. Dipped out there. What about a specific autosomal dominant kidney disease that's responsible for 5 to 10% of the patients with end-stage kidney disease in this country and all over the world, called autosomal dominant polycystic kidney disease? When I was doing a postdoc in Cambridge 20 odd years ago, the guys next door in the lab were this close to defining the genetics of ADPKD. I visited last year, they're still this close to defining the genetics of ADPKD. And that's the genetics, let alone how to tinker with the genetics, let alone how to fix it. Dipped out there too. What about unknown causes of kidney failure? The companies that produce various enzymes, for example, Fabrazyme, that can be used to treat Fabry's disease, would have us testing every person in this category to look for evidence of Fabry's. Treatment, maybe $100,000, $200,000 per year, lifelong. Prevalence about 1%. Oh, I'm moving on, I've only got a minute. Let's motor. Okay, glomerulonephritis is my other favourite cause. We have one genetic disease there, dysregulation of complement in atypical HUS. We identified one patient of all of ours at RPA. We transplanted them, the disease came back, we knew what to target, and if Teresa Anderson's here, she'd better close her ears, of course. It now costs us $500,000 per year, every year for life, to manage that with some personalised medicine. So I work at RPA, we see 77,000 ED presentations, 80,000 admissions, countless operations and over 500,000 outpatients. I don't think personalised therapy is the answer for all of those people. So can we afford tailoring, or should we stick with off the rack? In conclusion, ladies and gentlemen, gene-targeted therapies make excellent sense for a very small minority of patients. Genes aren't cheap to find, they're often complex and unfixable. Targeting genes is very expensive, sometimes dangerous, and genes do not fix multi-morbidity disease, which is the bulk of our patients. The future of health requires what we already do, Julie. Thank you.
Ladies and gentlemen, this is a gloves-off intellectual debate, and we would want nothing less here at Sydney Local Health District. My next speaker for the affirmative for the proposition personalised medicine is the future is Tat Garwood, a nurse at RPA, now working in informatics as part of the information communication technology team. Her parents called her Tatiana. She's known generally as Tat. A 7-year-old asked her if she was a potato. She has got a tattoo, and if you're lucky, she'll show it to you later. Ladies and gentlemen, please welcome Tat Garwood.
Oh, Steve. Did you miss the bit about the future in the statement, that personalised medicine is the future? You've given us a great example of what things exist today, but let's talk about today and tomorrow. I have to say also, standing here as a plus-size lesbian nurse that works in IT, that diversity is something that I hold close to my heart. And your comments about off the rack have me personally offended. Can I get an idea about how many nurses there are in the room? Awesome. So while I'm on a stage full of doctors, let's remember that what we have in front of us exists, but we can always think about the possibilities, and that's what we're here to talk about today. Also, just wanted to challenge the idea of general drug treatments for general issues rather than a targeted approach. Anybody that was here yesterday would have seen the great presentation by Associate Professor Christine Lin about the difficulties with pregabalin trial and how with the same level of efficacy, they actually had double the adverse events from the pregabalin than they did from the placebo. So let's just consider that not everything gives benefit, and the first principle of medicine is to do no harm. So while we're talking about giving out random things to random people for random effect, we need to also consider the adverse effects that those bring in. And if we look at what we can do in terms of getting the basics right, let's focus on that. My role as a health informaticist is to stand halfway between clinical spaces and halfway between IT, and to work as a translator for those two areas. So I'm going to take all of the fancy graphs that you've provided very well, thank you, Steve, and I'm going to put it into a story to hopefully make my point a little bit easier to understand. I'm going to take you on a journey where we look at the specifics. We're going to look at art as medicine and medicine as art, and working with our population on the strengths that they hold to be able to prevent harm rather than treat disease. I've got some old family photos that, again, from an IT perspective, we've been moving from paper to electronic, so I've had to scan them into the computer. This is me and my grandmother. You can laugh, but she's from Queensland. We need to consider the life that she had. Now, she had a great interest in fishing. She was an excellent fly fisherman. And every day when I stayed with her in the snowy mountains, she would describe the great art of fishing to me. And she was very specific about the type of fish that she wanted to catch and the types of fish that we would eat. She didn't want to go out and just throw a net out and try to collect as many fish and other debris as she could. She was very specific. She had very tailored plans in the way that she addressed things. And that's part of the art of medicine. It's not guessing. It's not collecting a lot of information without much effect. We need to be able to work with the resources that we have. This was the lake that was just near her home that held the salmon. And each day we would sit by the shore and I would lay my head on her lap, often falling asleep to the sound of her tummy gurgling from our nutritious breakfast, as she would weave traps to catch small animals and call birds down from the trees so she could see where the worms were. These worms were then used to make her amazing hooks to be able to catch those specific fish that she wanted to be able to catch. This is me fishing, one of the first days that I actually got to hold the rod myself. And I actually remember seeing this guy on MASH, Captain Blake, and realising that other people had hats like my grandmother's that were covered with the hooks for those specific fish. This is one of the freshwater traps that she used to weave. Now, part of her art was of observing nature in the same way that biologists have done since the beginning of time, being able to connect X and Y to come up with a cause and effect to be able to really determine the future of our race. We need to think about the benefits of having a totally efficient process such as personalised medicine in the future, where rather than broadcasting issues, we can really be specific and tailored. This was a homemade net that we used to catch butterflies. Next door to my grandmother's property lived a man that we affectionately called Bogan Josh. He was also a fisherman. However, his tactics were a little bit different to the art of my grandmother in that he used dynamite. Let's consider the unintended consequences of dynamite on the fish population and on the environment in general. And in an environment like today where we have limited resources, particularly from a health perspective, we need to consider what we're doing and how we're doing it and how that impacts our patients. Ultimately, we're talking about survival of the fittest. Unfortunately, this is now where my grandmother, or where she used to live, she's dead now. We need to have specific solutions to universal diseases. We need to develop the art of medicine rather than just assuming that what we have now is enough to keep us going into the future. We need to embrace the curiosity of the experts with whom we work and with whom we share this stage and our district. We owe it to our children. We owe it to our children. They are the future, Steve. We owe it to Grandma Joy Joy and to Bogan Josh. We need to have revolution through evolution, and personalised medicine is the future. Thank you.
I just simply said, I am in awe of you. That was a very good experience. Ladies and gentlemen, the second speaker for the negative, arguing against the proposition, is Victoria Weeks, a non-executive board member with Sydney Local Health District. Look, this woman's got a law degree, she's worked in banking, she's an absolute super brainiac, she's been on a million boards. But what's really interesting about it is her health history. She hasn't given me everything because some things are too private. But this is serious. She's had 1 tonsillectomy, 2 caesareans, 6 broken ribs, 1 broken shoulder, a hemopneumothorax, no idea what that is, but it's not good, minor hip surgery, presumably leaving more for room later, and 2 carpal tunnel surgeries. Ladies and gentlemen, she cares about the patient, Victoria Weeks.
I'm also short, and I'm not sure the microphones are designed to go low enough so that I talk over the top, but I will do my very best. Look, I'm confused. My learned friends in the affirmative clearly can't agree on what proposition they're trying to argue, nonetheless humorous, but they're clearly quite confused. And in fact, I think they seem to agree more with the negative, so eloquently set out by my colleague, Steve Chadban. So to continue on where Steve left off, I'm going to demonstrate why it is patently false to state that personalised medicine is the future, and for 2 reasons. Firstly, personalised medicine is already here now. It's not just a thing of the future. And secondly, personalised medicine is just one part of the future of health services, and it's not a panacea. So like a good debater, I was planning to dispel the arguments presented by the affirmative, but they're so bad I'm not going to even bother with that. So why do we dispute the proposition that personalised medicine is the future? Good clinicians have a focus on their patients. They listen to their patients and have been practising personalised medicine forever and a day. And you will have gathered from my bio, I have a lot of clinical experience as a patient. And I've had some great personalised medicine experiences and some not so great ones. Let me give you an example. Some years ago, I was admitted to the ED, not one of ours by the way, with a hemopneumothorax and 5 broken ribs. After they reinflated my lungs and I was recovering, I complained of being very sore on my right side and not being able to move. They told me it was my ribs, I was in shock, it would pass, and they also gave me some more morphine, which actually is a really, really good drug. A day later, after I complained a lot more, they x-rayed my shoulder to discover it was really quite badly broken. 10 days later, after I left hospital and was having trouble walking, my GP sent me off to get some more x-rays. It turned out I also had a fractured hip. If only they had listened. So personalised medicine does not require fancy, new, expensive technology. It just requires listening to your patient and their families. Recognising that they probably know way more than the clinician does about their own health and about their condition. It means having empathy, having trust and respect in a patient's right to participate in decision-making about their health. A clinician should not need my gene sequence to work that one out. If they do, we're in trouble. My second point is that personalised medicine is only part of the future, because particularly it can be elitist, expensive and miss most of the important population. Some more recent manifestations, which John was talking about, around personalised medicine, analysing a patient's DNA to confirm disease and treatment options, are at risk of being elitist by only addressing the needs of a small proportion of the population for very rare conditions, and bankrolling the health needs of very few to the detriment of the health system overall. Some of the most effective treatments are those things that we standardise and apply to our whole population. Things like childhood vaccinations, breast scans, fluoride in our water. Some of the simplest things made standard across our populations have made the biggest impact on our health. My third and final point is that personalised medicine has risks, and it can be an excuse by some clinicians for unwarranted variations in clinical practice and lead to poor health outcomes. Evidence-based, standardised approaches to healthcare across populations ensure our clinicians always have access to the latest thinking and apply best practice in how they treat their patients. Without consistency in standards of practice, there is significant room for unwarranted variations in clinical practice and letting clinicians just do their own thing as they will, not on my team, on my team. And some really wacky ideas and potentially dangerous, outmoded forms of treatment they might call personalised. Think low chemo dosing. But innovation today occurs at such a fast rate, it's difficult for clinicians to keep up with the latest and greatest, and we need new systems to ensure best practice is always applied. Health Pathways is a great example of this. Health Pathways, for those who don't know, is a web-based system that guides GPs on best practice clinical care, and the district's been a leader in implementing Health Pathways as part of an integrated care approach, providing a whole range of treatment plans and bringing together the insights from our leading clinicians. Health Pathways was established in Sydney LHD some years ago, championed by our fearless leader and CEO, Teresa Anderson, AM, and also our board. There are now over 1,100 Health Pathway users in our district alone, and in 2018 there were over 100,000 unique page views. We currently have over 600 Health Pathways on conditions ranging from newly diagnosed type 2 diabetes to urinary incontinence in women, a personal favourite of mine. Do you know that the single most accessed health pathway for a GP is what to do on the first antenatal visit? Nearly done. But that's kind of scary. The average GP today doesn't know what to do when their patient is pregnant. Imagine those doctors making it up as they go along. Personalised, no thank you, give me the latest, up-to-date, best practice health care for my condition. So in conclusion, the future is as much about applying consistent, best practice clinical care as it is about providing personal, patient-centred care that advances the health of all our patients, not just a few. Thank you.
Thank you so much. Well, we're moving to the hard end of the debate, and it's my great pleasure to now welcome the third speaker for the affirmative, a man who's had the gauntlet thrown at his feet. He's arguing personalised medicine is the future. His name is Professor John Rasco, AO. I think of him as the Gene Man. Please make him welcome.
Unaccustomed as I am to speaking, and unfamiliar with attacking distinguished colleagues on the far left of the dais, I want to highlight some flaws in the argument of my distinguished colleagues. I want to first of all say and address the issue that Steve raised of the follicularly disadvantaged. Now, I want to tell you that before this debate, our team prepared relentlessly to make sure that we could address the arguments that they were going to thrust in our direction. And as a consequence, Nick Glosey actually shaved his head in order to match Steve Chadban's, sadly bald head, in order to empathise with the other side. They have accused us of replacing empathy with genes and genetics, and it couldn't be further from the truth. We have an obligation as a species, as humans, as compassionate individuals, to seek the best health, the best life, and the best quality of life that we can offer one another. That is the fundamental goal of, I think, everyone in this room. And as part of that, personalised medicine is a component. I think it's always been a sad reflection of Steve that he chose the wrong specialty. Everyone recognises that renal medicine lags behind haematology. It's a problem. He's got friends that have been stuffing around for 20 years not getting the right genes. Sorry, mate, but in haematology we're nailing it. We've got all the genes, we know what's going on. Perhaps one day we can teach you about it. In the meanwhile, hey, let's get up to speed and see if we can join in our empathetic struggle to address the follicularly challenged. I'm also reminded of the fact that in the particular example that Steve highlighted, in the renal disease space, we willy-nilly treat people with drugs like the one he even mentioned, the ACE inhibitors. And what we've learnt over the last 10 years is that if we treat people with certain antihypertensives, some benefit and some don't. It turns out that those people who don't benefit are genetically determined. In fact, large population-based studies were done that Steve will recite to you that proved that black Americans didn't benefit from the most popularly prescribed antihypertensive. Duh. This isn't going to cost more if we know that people are fruitlessly taking drugs that can be genetically screened so that the rest of their lives they can choose one particular blood pressure lowering drug compared to another. Then we don't need to fruitlessly waste money on drugs that are going to have no benefit. So yes, it's sad that renal medicine has lagged behind some particular other areas, but I would also highlight the fact that personalised medicine doesn't just mean genetic medicine. It means tailor-made to the individual. Let's not confuse or be forced into a corner in mistaking just genetic testing with personalised medicine. Personalised medicine is the absolute epitome of what it is to be a physician. It is to serve the individual's interest above all else. It is the cornerstone of the Hippocratic Oath, and it is certainly a component of the past, and it is a component of the currents as I've lectured to you today, but it is also a burgeoning area of the future, and that's the proposition today, that personalised medicine is the future, not all of the future, but it is part of the future. And I think the fact of the matter is that the main argument that was raised by the negative was that it is going to be costly and it is highly selective and it is only for the rich. It couldn't be further from the truth. This is almost like shutting down all of technology and anti-research. And I know that Teresa will be furious with anyone who dares to suggest that research is anything other than the highest priority amongst so many other priorities that we have in the Sydney Local Health District. Cost always follows when competition and the market begins to compete. The cost of any new technology is often shocking, but I don't imagine that the negative is suggesting that we should ban penicillin or should we ban vaccines? Because at the very start, they were terribly expensive. They were very high cost to manufacture. But once the market gets involved, once competition starts happening, once cost of goods and manufacturing starts being considered and reimbursement starts being argued with penny pinchers and technically competent economists unlike me, then the reality strikes and costs go down and they become uniformly available. We see as economic development spreads throughout the planet that there are benefits to individuals who could never have dreamt of getting the benefits that we take for granted, and over years and decades those benefits will grow. The kind of research pessimism exhibited by the negative is absolutely a source of sadness, and I'm certain Judith will continue on into bringing us into the doldrums. In contrast, let us celebrate the life of Bogan Josh. Let us recognise the contributions of Shirley Temple, Tat Garwood and her grandmother with the beard. We owe it to our children to be sure that these technologies are embraced. We owe it to the future to offer the best medicine that we can, and personalised medicine, be it genetic, be it tailor-made technologies, be it using your own cells to cure your own self, in the case of regenerative medicine, are all of the areas that we would embrace. I will just touch on a couple of points that Victoria made. I don't need to reinforce any of the points that Nick made, because what our tactic was in that speech was to offer the smallest possible target to the negative so that they couldn't attack us. But now we're coming strong with the really big points. Simply in terms of Victoria's argument, she simply based her entire argument on the fact that she's had a series of accidents. I would suggest to you that she might take a little bit of vitamin D and some calcium. I would suggest to you that she perhaps get her gene sequence, and maybe there's some congenital osteoporosis. I'm just saying. And I am an empathic person. I'm trying to encourage good health in all of my colleagues, distinguished and otherwise. So the affirmative, I think, is arguing that simple is best. Easy therapies are the ones that we should go for. Big, technical, scary ones like Professor Rasko describes are scary and we shouldn't embrace them, but we can be empathetic always and share the compassionate kumbaya of the negative. Replace technology with a fireplace. So personalised medicine is part of the future of medicine and includes the best practices that we have to offer. Thank you very much.
Ladies and gentlemen, this is just so much fun. Our third speaker for the negative is Associate Professor Judith Trotman, founder and director of the Clinical Research Unit, Concord Haematology. Look, last week she published an article on precision medicine in lymphoma in the New England Journal of Medicine. That's what we call, that's like a logie. Precision medicine. I do beg your pardon, personalised medicine. But I find it equally interesting that she has 6 children ranging in age between 16 and 33, including 2 sets of boy twins. Would you please welcome Wonder Woman, Associate Professor Judith Trotman.
And I can tell you the one daughter was more work than the 5 boys put together. Now, I really feel, after the affirmatives debate, that I really need an extra 5 minutes for rebuttal. But first, can I say kia ora? As a proud New Zealand migrant, I too acknowledge the Gadigal people, the local Indigenous population, the people of Redfern, to whom our Chief Executive has publicly committed they will have the best health of any Indigenous population. Woohoo! Because yes, while she cheers on John Rasko and the other poster boys of precision, of personalised medicine, Dr. Anderson, AM, woohoo, knows that personalised medicine is passé. It's yesterday's catch cry. Teresa is focusing on her 1 million people, knowing that primary health care, population health, is the future. She wants the children from Punchbowl to Panania to have preventative health and a proper breakfast each morning. Dr. Anderson's vision is a medicine that is less about me and more about us. And in this district, together we deliver that vision. Now, ladies, weren't you almost taken in? Weren't you almost swayed by that posh London accent of Professor Glosier? Now, you know the personalised medicine enthusiasts have a very limited talent pool when their first speaker is a psychiatrist who did nothing to establish their argument. Indeed, he helped us establish ours, and is clearly only on the team to help Tat with her perambulating and Tat and John work through their compulsive psychoses and paranoia. Thank you for your pity, Nick. However, we don't need it. How appalling. Do I get an extra 2 minutes for that? All right? How appalling to appeal to you that the humanistic approach is in the future. Nick, the humanistic approach is here and now in our medicine that we practice today. I pity your current patients if you don't have a humanistic approach already. The aloof British stiff upper lip just won't cut it with the average Australian schizophrenic. Now, Ms. Garwood was actually invited to join Victoria and my team, but no, she was persuaded by the personalised medicine punchlines of our two important male professors. Tat, we are told there's a special place in health for women who don't support women. You getting the feminist theme here, ladies? And I am at a distinct disadvantage to her. How can such a slim, married, white doctor with 6 kids possibly debate a plus-sized lesbian nurse? But at least you should tell your grandmother to shave. She argued that the sheer volume of renal disease is not the disease of the future. And yet we all know, we all love our Big Macs, we all love our red wine. We're getting fatter, our livers are getting fattier, we're all getting older, and renal vascular disease will continue to be a scourge, won't it, Nick? Incurable by gene therapy. Nick has not just got lots of patients, he's going to have lots and lots of patients in the future. And did you all get that fishing analogy? I think she was just fishing for your sympathy. And as for Bogue and Josh's dynamite, I can't go there. I just don't get it. Now, let's move on and compare the credibility of Professor Rasko, our radio national star, the man of the media, the king of spin, with his 9 Twitter followers, and Ms. Garwood and Prof. Glosier with 20. Let's compare them with our MC, Ms. McCrossin, creating a storm on Twitter with thousands of followers, who was cured of her throat cancer by radiotherapy, the sort of one-size-fits-all, low-cost therapy so maligned by our opposition. And let's also note Ms. McCrossin's support for population-based prevention, as she champions on Twitter the implementation of HPV vaccination globally. Julie's advocacy for population health will save thousands of lives while costing a pittance. Ladies and gentlemen, please applaud the greatest healthcare walker in the room. Come on, up. We see through Dr. Rasko's attempts to pretend personalised medicine is not precision medicine, right on the back of a 30-minute oration about the glories of gene therapy. And as for challenging Nick's alopecia, that's a dangerous place to go, Professor Rasko.
You started it.
As a colleague from a small H haematology department, I must, however, congratulate Professor Rasko for recently helping to cure 1 of the billion people with thalassemia in the world. However, well before gene therapy, we have had the much cheaper, personalised pre-implantation diagnostics, and it too has hardly made a dent on the huge global burden of thalassemia. Do we really want the professor's prohibitive medicine from Prince Alfred bankrupting our district so we can't afford the speech pathologists and the continence pads for the elderly at Canterbury, the physiotherapists at Balmain, the pacemakers and the PET scanner at Concord? Ladies and gentlemen, Ms. McCrossin exhausted the women of the district to understand a financial balance sheet on Wednesday. Fortunately, Ms. Weeks is a financial whiz who can inform the board of the prohibitive financial balance of a pricey preoccupation with precision medicine, and she also does chair the research committee. Ladies and gentlemen, Victoria and Steve, no, I've got an extra 2 minutes because of you, all right, have highlighted that personalised medicine is so yesterday. We haematologists, we've been doing personalised medicine for years, curing patients with leukemia and lymphoma with our enzyme inhibitors and antibodies. And yet we risk bankrupting this nation with our precision medicines, with 9 of the 10 highest priced drugs on the PBS at a staggering $2.5 billion a year. My clinics are filled with survivors who take these pricey prescriptions, and now the only personalised medicine they want is their doctor to be prompt, their pathology to be precise, and a bloody printer that works. And throw in a bit of parking too, please. Ladies and gentlemen, the medicine of the future is not about the pricey me, it's about the affordable us. And so I finish with a Maori proverb quoted recently at the Great American Oncology Meeting, because it's not about the person, it is about the people, it is the people, it is the people. Thank you.
Ladies and gentlemen, that's one of the liveliest debates I've ever emceed. Absolutely astonishing. It is now up to you who wins. We're going to use the clap-o-meter. If I could have the 3 speakers for the proposition, Professor Nick Glozier, Tat Garwood and John Rasco, stand up, please. If you support those arguing for the proposition, clap now. Thank you. I have to be neutral in all that I do. And if I could ask you to sit down, and could Steve, Victoria and Judith stand up. If you support those against the proposition, clap now. Teresa, I reckon it's equal, don't you? Look, I know that these rather competitive souls will find equity a little bit challenging, but I dead set think you were equal, and so just hoot for the 6 of them, would you?